12 noon. So, hello everyone. Thank you very much for joining us today in the Queen's Cancer Research Institute seminar series. And today is our last of this seminar for the year 2023. And on behalf of the Division of Cancer Care and Epidemiology of Queen's Cancer Research Institute, it's my big pleasure to welcome today's speaker, Dr. Michael Raphael from Sunnybrook Hospital, University of Toronto. He is an assistant professor in oncology, and he's a medical oncologist, a GI cancer oncologist there. And he's a very dear friend of mine. In fact, we overlapped for almost 8-9 months during our fellowship here at Queen's. So he's our own Queen's alumnus. And he has gone to Toronto seeking greener pastures. And in Toronto, he has found the cure for cancer. So his title of the talk today is How to Cure Cancer. And as in his abstract, you must have seen, he's going to tell us the secret way to cure cancer. So it's my big pleasure to welcome Mike to our seminar today. Mike, the floor is all yours. Thank you very much for doing this.
Thank you. Thank you. I'm so excited to be back virtually at the very least. As Vishal mentioned, my name is Michael. I'm a medical oncologist over at Sunnybrook at the Odette Cancer Center. And I'm an extremely proud Queen's alumni. I did my medical school at Queen's, and then I went back and did a fellowship with Chris, where I overlapped with Vishal and got to meet a number of people who are on this call today. So I'm very excited to scroll through this list and see the names and some faces that are quite familiar. People know that I have a little bit of a flair with the way that I do things. So like always, I'd like to start off this talk with a little video to get everyone hyped up and excited, and hopefully the sound will work for everybody.
Mike, we can't hear the sound. We only see the video.
Oh no, the sound doesn't work. All right, well, this is the first fail, but I think that's because I need to click something on this thing. Okay, anyways, we're gonna forego the video, which I promise you was amazing. And I'll jump right into the talk because I know we've got just you on your lunchtime. So what I'm going to tell you today really is the secret about how to cure cancer. Now, this is a secret that is very familiar probably to many on this call, because much of what I'm going to talk about today I've learned from the likes of people like Chris and Vishal. So if you've already heard Chris and Vishal speak, you're going to hear a lot of the same themes, but I'm hoping to present this in an interesting and thought-provoking way. So I have no disclosures as a true booth trainee. I do not accept money from the pharmaceutical companies. But I do have one disclosure to make, in that I've given a previous version of this talk at Queen's before, a couple of years back. And during that, I used up all of my best proven jokes. So I'll now be moving to my phase 1 jokes for this talk. And we all know the response rate to phase 1 is not as great as it can be. So that is my one caveat. So in terms of the objectives for today, I'm going to tell you the secrets about how to cure cancer. I'm going to discuss this concept called the break-even point in cancer drug development and why it's so important in our attempts to actually cure cancer. And I'm going to try to demonstrate to you that our current drug development process is not efficient, economical, or equitable. So when the provocative title aside, what I'm going to try to make the argument today is that there are really only 2 ways to cure patients of cancer. The first is to develop an effective cancer medicine that can result in cure. But the second equally important way is to actually get those cancer medicines to patients. And in today's presentation, what I hope to show you is that while both are equally important in the fight to cure cancer, a disproportionate effort and investment have gone into developing new cancer medications, and relatively less attention and investment have gone into ensuring those medicines actually get to the patients who need them. And this is one of the major principles behind Vishal and Chris's and others' movement in the Common Sense Oncology initiative, is Yes, fancy, new, exciting medications are important, but it's also important to make sure that we actually are getting those medications to patients. But first, let's start off by reviewing some of the extremely effective cancer medicines we have that have indeed revolutionized the way we treat some patients with cancer and have really provided an incredible amount of hope. And so most on this call will recognize this medication, imatinib or Gleevec, which is perhaps the most revolutionary cancer treatment discovery of the past 50 years. So we all know that Gleevec is a small molecule inhibitor that's used by our hematology colleagues in the treatment of CML, among a few other indications. And this Kaplan-Meier curve shows why imatinib truly was and is a breakthrough and revolutionary cancer medicine. This Kaplan-Meier curve is really the ambition of every new cancer medicine and oncology. The 5-year survival of patients who are treated with imatinib for CML is now greater than 90%, compared to less than 50% for older, more toxic therapies. And because of breakthroughs like imatinib and some of the newer generation inhibitors, the life expectancy of patients with CML is now approaching that of the general population. So this really is a truly remarkable story about a revolutionary and transformative medication that has helped patients live longer and better lives. If we move into the solid tumor space, we can see that the EGFR inhibitors for lung cancer in certain spaces have improved the outcomes for many patients. We now, in fact, have 3 generations of EGFR inhibitors. And because I only treat GI cancers, there may, in fact, be even more that I'm just not aware of. But if we try to understand the general benefits of these EGFR inhibitors and how much they've helped patients, one only needs to look back at the past 50 years of studies for the treatment of lung cancer. And if you look at the median overall survival for all of these phase 3 clinical trials, we can see that most patients with lung cancer in the best performing arm, unfortunately, were living less than 1 year. And so to put that into perspective, if you look at this study that looked at the use of one EGFR inhibitor, one of the 3rd generation EGFR inhibitors, osimertinib, and we look to see that the median overall survival is approaching almost 40 months. And then you compare that to the table we saw before, where the median overall survival for almost all of these patients was less than 1 year. We can see that this is another revolutionary and transformative drug, an oral medication that patients can take that's generally well tolerated, that is resulting in significant improvements in overall survival and in quality of life, especially in compared to these more toxic chemotherapy regimens that had very little efficacy and effectiveness. So far we've talked about imatinib and about the EGFR inhibitors. These fall into the general category of those targeted therapies. But of course, you can't give any talk on oncology without talking about immunotherapy. Immunotherapy truly has revolutionized the care and management for many types of cancers. And so the immunotherapy era in oncology really started in the melanoma space. Metastatic melanoma was a cancer that had almost no effective cancer treatment options. In fact, there had never been a randomized controlled trial that showed that any agent substantially improved overall survival. And then we saw ipilimumab, one of the earlier immunotherapies that targets the CTLA-4, which was shown in a series of trials published in the New England Journal of Medicine to significantly improve overall survival. And what we started to see in these immunotherapy trials that's become a fundamental part of teaching in oncology is this tail of the curve, this flattening of the curve, where we're no longer seeing patients that are dying. And so, in fact, these patients may actually be cured of their cancers. So this is truly a breakthrough finding, a disease site that had absolutely no effective therapies. And now with immunotherapy, you're seeing some of these patients cured of their cancer and going on to live long, healthy lives. And with further refinements in our knowledge and understanding of immunotherapy, we've now moved into the dual immunotherapy era, where you can see that patients with metastatic melanoma treated with dual immunotherapy have overall survival that is now past 50%, approaching 60%. So again, truly, truly revolutionary and life-changing stuff for our patients. If we go outside of the melanoma literature and we start looking at the population of patients with deficient MMR or MSI cancers, we can see that pembrolizumab can be a dramatically effective medication for these patients. This Kaplan-Meier curve comes from a basket study that was published in the Journal of Clinical Oncology. This trial, now among many others, has shown that among patients with deficient MMR tumors, approximately 1/3 of patients will respond. And more exciting than that 1/3 number is that if these patients respond, the responses can be incredibly durable and long-lasting. And you can see here this tail of the curve at 2 years, where no longer are we seeing drop-offs in the Kaplan-Meier curve. So these are patients, again, who are likely to be, hopefully, likely to be cured of their cancer. And we can see now that pembrolizumab has been approved by the FDA in what's called a tumor agnostic phenomenon, meaning that it's not just approved for colon or lung cancer, but any patient with an MSI cancer can theoretically benefit from this. Now, just to be clear, we do not have that same sort of approval in Canada. Certainly, we are working on it. But this was the first proof that we can use an agent regardless of cancer site based off of a molecular feature. So just one example, this was a 34-year-old patient of mine with metastatic MSI gastric cancer. This is a patient who was known to have Lynch syndrome. At baseline, back in January of 2020, you can see that he had an approximate 11-centimeter liver metastasis. This is a devastating situation for the patient, the family, frankly, for the oncology and the care team as well, because 5 years ago, this patient would have had no other treatment option other than chemotherapy. Chemotherapy for gastric cancer is modestly effective at best, and unfortunately, most of our patients die within 6 to 12 months. So 5 years ago, I would have had nothing to offer him except chemotherapy, which would have come with symptoms and would have very modestly, if at all, helped him live longer. This is a young guy, a family, a full life ahead of him. I was able to enroll him in a clinical trial with the use of single agent pembrolizumab. And you can see that after 13 doses of pembrolizumab immunotherapy, the tumor is almost completely gone. This patient has now completed his immunotherapy course of 2 years and has been on observation for almost the past 2 years with no evidence of cancer recurrence or spread. He still has this 2-centimeter lesion within the liver, but multiple studies have now shown that if you go in and operate on these patients, they may not have any cancerous cells remaining at all. It may all just be scar tissue and immune infiltration. So this is truly a remarkable result. Again, 5 years ago, this 34-year-old young gentleman with a family would have died within 6 to 12 months. And now with a reasonably well-tolerated single drug, we can provide what is hopefully a long-lasting cure. So we've talked about targeted therapies, we've talked about immunotherapies, but let's not forget about good old chemotherapy. We've known for almost 20 to 30 years that cisplatin-based chemotherapy can cure many patients with metastatic non-small cell, non-seminomatous germ cell cancer, pardon me. And we can see that testicular cancer is treated with cisplatin-based therapy, can have 10-year overall survivals greater than 95%. So although it is a chemotherapy, cisplatin is an extremely important medication that routinely cures people, even with metastatic disease. And I would call this, and I think most people would call this, a revolutionary treatment discovery for our patients. And so up until this point, I have obviously showed you some pretty remarkable results with targeted therapies and immunotherapies. But it's important that we ask ourselves, how many patients benefit from these treatments? And on average, how much do patients benefit from these treatments? So this was a study that was led by Dr. Prasad, who many of you know now at UCSF. And this was a cross-sectional study that looked at all drugs that were approved by the FDA and looked at the estimated percentage of cancer patients who were potentially eligible for those newly approved immunotherapies. And the authors found that if you look at all patients within all cancer types who might have an indication based off of the FDA approval, approximately 44% of US patients with cancer could potentially be eligible for immunotherapy just based off of the type of cancer that they had. Next, the authors asked the question, how many patients benefited from immunotherapy? And using a very lenient definition of the word benefit. So we're not talking necessarily about improvements in overall survival or improvements in quality of life, but this could be any benefit, improvements in response rate, improvements in progression-free survival. You can see that of the 44% of patients who are potentially eligible, only 13% of US patients with cancer were benefiting from immunotherapy. The authors then went on and repeated the same study looking at targeted therapy. And if you look at all the FDA approved indications, approximately 8% of patients in the United States are eligible for treatments that are targeted therapies. And then again, if you look down how many of those patients actually benefit, you can see that it's only 1% of patients who are eligible are benefiting from therapy. So we can see that these medications, although we hype them up because they provide so much hope to ourselves as the oncology community, to our patients, to our families, these are unfortunately not a good treatment option, and they benefit even less for the majority of our patients. And we always like to talk about our successes. None of us like to talk about our failures, but it's important so that we can normalize the fact that unfortunately these drugs that we use do not always help our patients, and they are not the panacea that sometimes they're made out to be. So this is a patient of mine, 40 years old, who had metastatic MSI-high colorectal cancer. This is her baseline imaging showing a 2.6 centimeter metastasis. I gave her 4 cycles of pembrolizumab, and you can see that unfortunately there was a dramatic worsening of her radiographic appearance, and this corresponded with a dramatic worsening in her tumor markers and her clinical status, and she died shortly thereafter. This is a patient of mine who was 27 years old with metastatic gastric cancer. We're able to get him compassionate access to immunotherapy, and after 2 doses of access, you can see that there was a dramatic worsening in his CT scans, and he too, unfortunately, passed away shortly thereafter. So while immunotherapy can work, and it can work dramatically for some of our patients, unfortunately, it does not work for many of them. We need to be honest about that. It's important that we ask for the therapies that we give, how much on average do these patients benefit from these therapies? So this was a study that looked at all cancer medicines which were approved by the FDA between 2002 and 2014. Almost every single one of these drug approvals was for a targeted therapy or immunotherapy. Very few of them were for actual chemotherapy. And to recall, these are only the drugs that were deemed good enough in terms of their benefit by the FDA to actually get approval. All of the lesser effective drugs never made it to this mark and never got FDA approval. Among 71 cancer medicines, the median progression-free survival benefit of a new drug was 2.5 months, and the median overall survival benefit of these drugs was 2 months. And if we think about the fact that we do CT scans on patients with metastatic disease approximately every 2 months, these drugs are basically lengthening it by 1 CT scan interval. So it's very possible that these patients have even less benefit, and it could have progressed after 4 weeks or 5 weeks or 6 weeks, and we're just picking it up at the 2-month mark when we are doing these CT scans. So while I would never argue that an improvement in overall survival of 2 months is not an advance, most of the benefits we've seen in oncology have been incremental like this, and we build upon these to do better for our patients and our families. I think that we have to be realistic and say that these benefits are modest. These are not the revolutionary benefits that we all want for our patients, and frankly, that our patients deserve. You might say to me, because this is a really smart group of Queens people, as I said, I'm a very proud Queens alum, that maybe it's not fair. You know, Dr. Avely, you presented some very selective cases of immunotherapy working well, maybe you're presenting very selectively the results of these studies and making it look like the drugs aren't as good as they are. Maybe it's not fair to present the median survival values. And if we look back at this figure, which I presented before, it's important that the tail of the curve provides most of the benefit in immunotherapy. And for the people on the call who have a background in statistics, they'll know much better than I that because these Kaplan-Meier curves demonstrate non-proportional hazards, often this late proportion, because of this late post-progression benefit, it sometimes is not fair and not valid to use the median overall survival benefit because it ignores all the benefit that is being realized at the end of the curve. And so now people much smarter than I have proposed using things like the restricted survival time, the restricted mean survival time, which may better account for this tail of the curve. So the restricted mean survival time refers to the direct quantification of the benefit over the entire survival curve. Because this measure takes the average, i.e. the mean and not the median, to summarize the entire survival profile, it does not rely on the proportional hazard assumption and should theoretically capture the benefit across the entire trial. So someone much smarter than I, my colleague, Dr. Kelvin Chan, who in addition to being a wonderful colleague and a medical oncologist, also has both a master's degree and a PhD in statistics, said, okay, let's look back at all these FDA approvals for cancer medicines between 2006 and 2017, and let's try and quantify the benefit in multiple potential ways. Let's not only look at the median overall survival benefit or the hazard ratio, but also let's look at the restricted mean survival time. So they looked at 107 trials leading to FDA approval of a cancer medicine. They actually went and back calculated using some fancy software, the restricted mean survival time. And you can see that when you look at it, it's only 1.83 months. So the bottom line here is that no matter how you compute survival, the benefits of these newly approved cancer medicines are modest for most clinical trials patients. And why is that point important to bold and to highlight? Because one of the very first things that Chris taught me in my training was that the clinical trials patients do not well represent the patients we will see in our routine clinical practice. These patients are younger, they are fitter, and they are less comorbid. And Chris would refer to the trials patients as the Olympians. And so this is not just a theory, this has been shown in practice multiple times. This was another study led by Kelvin Chan, where he looked at what we know as the efficacy effectiveness gap. So efficacy refers to the benefits seen under ideal conditions that are witnessed in clinical trials. Effectiveness refers to the benefits that are seen in the real world with all the imperfections and uncontrolled conditions that we face. So the x-axis here shows cancer medicines which are currently funded by Cancer Care Ontario. The y-axis shows the median overall survival difference between what was reported in the landmark clinical trial and what is being measured in routine clinical practice in Ontario, Canada. And you can see that for 28 out of 29 cancer medicines, patients treated in the real world had worse survival, with the average survival difference being up to 5.2 months. So we have not yet even considered cost, but it's important to say that we may be approving some medicines that have very little to no benefit when they are used in the real world setting. And that leads to multiple questions about how we should be approving these drugs, and should we be approving drugs conditionally and then using real world evidence to reevaluate those drugs. And this is something myself and Bishal and Chris have written about. And this is something that Kelvin Chan and the CAN Revalue Initiative are looking at. And these are very important questions, but that's a full talk in and of itself. So the summary up until this point, and what I hope I've shown you, is that we have some very effective cancer medicines that have revolutionized the way we treat some patients with cancer. But these revolutionary cancer medicines are the exception rather than the rule. And unfortunately, most new cancer medicines are of modest benefit to our patients and families. And this is where I'd like to make the argument that we are going to have a much greater chance and much more immediate success in improving cancer control and improving cure at the population level by improving the fidelity with which we deliver our existing effective cancer medicines to patients. And this is where I'd like to introduce one of the most important papers that I read in my health services research and epidemiology study. This is a paper that was published in a very obscure journal, the Annals of Family Medicine, back in 2005, where Wolf and Johnson made the argument about this concept called the break-even point. And this will be something that Chris and I are summarizing in an upcoming editorial if I can get my act together and get that submitted. So the break-even point. Say you have a disease that results in 100,000 deaths per year. Say you have a drug that reduces the rate of death by a relative factor of 20%. So we have a relative risk reduction of 20%. If 100% of eligible people receive that drug, that means that 20,000 deaths will be averted. That is the relative risk reduction times by the number of deaths per year. If only 80% of patients receive that eligible drug, 16,000 deaths will be averted. That will be the relative risk reduction times the proportion of patients who receive that drug times the number of deaths. And so if we say that 80% of people are going to receive that drug, if we want to improve upon our success, we want to reduce the number of patients who are dying from cancer, we have only two options. We can develop a more effective cancer medicine, developing a drug that has a relative risk reduction greater than 0.2, or we can work to get the existing effective cancer medicines to more patients, deliver the medicine to greater than 80%. And this is something that we can generalize for any cancer medicine. So I'll walk you through this graph. The x-axis here shows the relative risk reduction for any cancer drug, and you can apply this to any non-cancer drug as well. The y-axis shows the number of deaths that are averted by that drug. So for example, we said that if you have a drug at the very beginning of the x-axis that reduces deaths by 20%, if you deliver that drug to 80% of people, you're going to avert 16,000 deaths. And if you deliver that drug to 100% of people, you're going to avert 20,000 deaths. And we can generalize that relationship between the relative risk reduction of the drug and the population level access of the drug and the resulting number of deaths that can be averted by plotting a figure like this. The dashed line here on this curve shows the number of deaths averted with a drug that's given to 80% of the population with progressively more effective cancer drugs. So if we start off at the very left side of the x-axis, we've already shown that if you have a drug that reduces the risk of death by 20%, if you get it to 80% of the population, you will avert 16,000 deaths. If you follow this dashed line up towards the right side, you can see that if you have a drug that reduces the risk of death by 25%, you will save 20,000 lives if you only continue to deliver that to 80% of people. Now, if you have a drug that reduces the risk of death by 30%, and you deliver that to 80% of people, you can look on this line and see that you will avert approximately 24,000 deaths, and so on and so forth. And you can generalize this level of population access for anything, 60%, 40%, 100%. So then you ask the question, how much better must a new cancer medicine be in order to save as many lives as you could by simply improving access to our existing effective treatments? So this figure will help us answer that very important question. We've already established that if you want to save 16,000 lives, you can develop a drug that is 20% effective at reducing deaths and get that to 80% of the population. Let's say you want to do nothing at all to improve the percentage of patients who get access to that cancer medicine, but you still want to save more lives. Maybe it's an election year and you want to be able to say, hey, look, we approved this new cancer medicine and we've saved 4,000 lives. What you can do is you can either develop a drug that goes and reduces the risk of death up to 25%, or you can deliver that drug to 20% more people. And what you could do, just for time purposes, is generalize this equation. And this is the break-even point. The break-even point tells you the point at which, the break-even point tells you the efficacy of a new drug that must be exceeded in order for it to improve you delivering that drug to more patients in the population. And what's very important to recognize about the break-even point is that the lower the existing access is to that drug, the greater a new drug must be in order to achieve the same benefit as simply getting that drug to more patients. So let me show you why that is a very, very difficult task to achieve. So when we think about these two potential options, either developing more effective cancer medicines or getting those existing effective cancer medicines to more patients, it's important that we ask ourselves, which of these methods is more efficient, which of these methods is more economical, and which of these methods is more equitable. So let's first ask, how efficient is it to develop a new cancer medicine? Well, we know as a group here that it's a very long process with a low success rate to develop a new cancer drug. The probability that a new cancer drug tested in a phase 1 clinical trial will ever reach regulatory approval is approximately 5%. And the median time it takes for that new cancer drug to reach regulatory approval is over 7 years. So it's a very slow process that is very inefficient. How economical is it to develop a new cancer medicine? Well, we all can guess that the cost to bring a new cancer drug to market is astronomical. And this study showed that it costs approximately $650 million to bring a new drug to market from preclinical development to market approval. But please, please, please do not feel bad for these companies. These companies are making a lot of money because although it costs $650 million or so to bring a new drug to market, the cost and the revenue that these drugs bring into these companies is substantial. So this was a very interesting study. It looked at 10 recently approved medications by the FDA. The dark green shows the total research and development costs for these drugs. The light green shows the revenue since approval. So if you look at just these 10 drugs with a median of 4 years of being on the market, the total research and development cost for these 10 drugs was $7.2 billion, but the total revenue and sales was over $62 billion. So these drug companies are doing just fine. From a patient and payer perspective, it's very clear that developing new cancer medications is not a very economical option. This figure here shows the mean monthly cost for oral anti-cancer medications and how extraordinary those costs are. Since 2000, there have been 32 new orally administered anti-cancer medications introduced to the market. The mean monthly spending has increased dramatically from approximately $1,900 for a drug in 2000 up to $11,000 for a drug in 2014. And so as an oncologist seeing patients, when they want to know, well, how much would it cost for me to pay for this new cancer medication? The answer is almost always approximately $10,000 per month for any new cancer medication. But you may say to me, you know what, doctor, after cancer medicines are on the market for a few years, the prices are going to go down, right? If you were to try and buy an iPhone original, it may only cost you $400 because now we have several generations of new iPhones that are there that are more fancy and have more features. But that is actually not what happens in medicine at all. Take, for example, erlotinib. It's one of those EGFR medications used for lung cancer that I mentioned before. It was approved in 2004. In 2004, the cost of 1 month supply was approximately $2,900. The cost of a 1 month supply 10 years later in 2014, despite the fact there are multiple new generations of medications, has gone up to $6,052. That is an increase of 200%, which far exceeds any reasonable rate of inflation. And it's pretty crazy given the fact that there are now multiple other Me Too medications that exist. You may say, well, competition and availability of multiple medications of the same mechanism will drive down the cost. I've just told you that's not true. Here's another example, imatinib, that breakthrough medication that we talked about, approved in 2001. 1 month supply cost approximately $3,300. 10 years later, despite the fact that there were multiple new medications within this class, the cost has gone up to $8,479, an increase of 250%. So it is not really efficient. It is not really economical to develop these new cancer medicines. And how about equity? Well, I think we can all guess the answer to this question, that it's likely going to be a very inequitable strategy to focus on new drug development rather than increasing the fidelity of our drug delivery. So let's look at this first from a local perspective, and then we'll look at this from a global perspective. A lot of this work comes from Queen's and the work that Chris and others like Tim have done. And this was one of Chris's earlier studies that showed that right now, even within our so-called universal healthcare system, there is already considerable evidence that vulnerable population of patients receive differential care. This is a study that showed that among patients with breast cancer in Ontario, those from lower SES backgrounds are less likely to receive guideline concordant care. For example, they have significantly lower odds of receiving adjuvant chemotherapy when it's otherwise indicated, significantly lower odds of receiving adjuvant radiotherapy when it's otherwise indicated. And these differences in care, in part, lead to profound differences in cancer outcomes for patients in Ontario. This bar graph shows that among patients with breast, colon, and rectal cancer, there are striking differences in 5-year overall survival, depending on one's SES. So if we do absolutely nothing to address the structural inequalities that are already preventing patients from vulnerable populations from getting access to these existing cancer medications, then developing new cancer medicines is certainly not going to help them. And unfortunately, this is exactly what we see is happening with our population level data. Again, another study from Chris that is now quite old, showing that even back in 2010, disparities in cancer outcomes are in fact worsening over time. This figure illustrates that in all time periods, those from higher SES backgrounds consistently have better cancer outcomes than those from lower SES backgrounds. And there's a clear dose response here that you can see. The poorer you are, the less optimal your outcomes are. And what's most concerning is you can see that the slopes of the lines are separating further and further over time, with those from more affluent communities getting better and better outcomes than those from lower SES communities. From a global perspective, the inequities are even more striking. So this is one of the most interesting studies I've read in the last few years that really aimed to answer the question of how inequitable is the distribution of our benefits from our research at a global level. This study looked at 34 drugs which had gained FDA approval in the United States between the years of 2012 and 2014. They then went and looked at what countries participated in the seminal clinical trial that was used to support FDA approval. And they asked how many of those countries that participated in that clinical trial eventually ever got access to those medications. These patients and their families and these investigators donated their time and their effort, their blood, sweat, and tears to these trials. Did they ever benefit from actually seeing those medications in their own communities? This figure shows that from a global health perspective, there is a clear inequitable distribution of research benefits. So the x-axis here shows the time to market access following FDA approval in the United States. The y-axis shows percentage of countries gaining market access to those drugs following FDA approval. Following FDA approval in the United States, you can see that access within 1 year to those medicines occurred in 13% of other high-income countries and no upper middle income and no lower middle income countries. And you can see that even after 5 years, the overwhelming majority of lower middle income countries and upper middle income countries still do not have access to these drugs. And again, just to emphasize, the patients and the families donated their bodies and their time to participate in these clinical trials to result in drugs being approved in the United States, and they never got access to those drugs in their own communities for their own family and their friends. So clearly, this is not an equitable treatment. Moreover, I think we're all aware of the exorbitant cost of healthcare in the United States, but we all know that cost itself does not tell the whole story. This study evaluated the monthly price of 8 patent cancer medicines in 7 countries. On the far right of this figure, you can see that the costs for these medications is far and away the most expensive in the United States, but cost does not tell the story. If you normalize this figure by expressing the cost as a percentage of the GDP, what they've expressed here is the purchasing power parity, what you can see is that although the cost is highest in the United States, in terms of affordability, it is vastly more unaffordable in countries like India compared to high income countries like the UK and the United States. So what I hope that the preceding slides have shown you is that focusing a disproportionate amount of research and investments on developing new cancer medicines is not the most efficient, economical, or equitable strategy. And over the next few slides, and I'd like to leave a lot of time for questions and discussion, is that there are things we can do that are quite simple to improve outcomes for our patients. And I'll pick some Queen's specific examples. So this is one of the first research projects that I ever worked on at Queen's with Chris and Jim. And this is a study that looked at the use of adjuvant chemotherapy for colorectal cancer. And so basically, we have over 2 decades of research to tell us that giving chemotherapy after colon cancer surgery improves overall survival by approximately 20 to 25%. And what we know is that chemotherapy in the adjuvant setting is best given as soon as possible after surgery before the cancer has a chance to establish itself and form metastatic deposits. So we looked at a systematic review and meta-analysis that found 10 eligible studies involving 15,000 patients. And we asked the question, what is the impact of delays to the initiation of this chemotherapy on survival outcomes? And we found that for every 4 weeks of waiting for adjuvant chemotherapy, the risk of death increased by 14% in relative terms. And so what is the impact of this on an individual patient? So if you take a 65-year-old patient in good general health with a stage 3 colon cancer, we can estimate that the 5-year overall survival for this patient, if they were to receive timely initiation of adjuvant chemotherapy, is about 60%. If you delay that by 4 weeks, it drops down to 54%. So a 6% absolute decrease in survival. That drops down to 48% if you have an 8-week delay in therapy. And so Jim went on and looked at the reasons, and some may say, well, Mike, that's useless. People start chemotherapy when they're ready. People may not start chemotherapy because they're still recovering from surgery. And this great work from Queen's also showed that 75% of the time, it actually is just administrative delays, such as waiting to get a port or a PIC, or waiting to get an appointment with an oncologist. So there are lots of inefficiencies in our system that could be optimized in order to improve outcomes for our patients. And remember, I told you that the lower the existing access is, the better the new drug must be in order to pass that break-even point. And you might look at this curve and say, well, Mike, it's crazy. You know, there's no way that there is a drug that improves overall survival that's only given to 60% of the population. So some of these are just wild examples. Well, unfortunately, that's also not true. If you move to the bladder cancer literature, there's decades of research to show that giving chemotherapy before surgery improves overall survival by 5 to 10%. Studies that I worked with Chris on show that unfortunately the vast minority of patients were getting treatment with neoadjuvant chemotherapy, even though there's great evidence to show that it was beneficial. And so you can see that we fall well below the standard of care in many aspects of oncology. So there's a considerable amount of improvement, such that it would take very little for us to improve the fidelity of delivery in order to improve outcomes for our patients. So I think, and I hope that I've shown you that focusing on improving the fidelity of treatment has the potential to offer much greater and more immediate benefits towards reducing the burden of cancer at a population level, particularly when one looks at it from a global lens and with an equity perspective. And so in conclusion, before we move on to this discussion, my takeaway from this has been that new cancer medicines provide hope for all patients living with cancer. And I do not think that anyone would argue against that. New cancer medicines dramatically improve the outcomes, though, for just some patients living with cancer. And new cancer medicines can do nothing to help patients and families who never get access to those medications. And so, a balanced approach to improving cancer control in Canada and globally and will involve the equal investment in cancer drug development and improvement in the fidelity of cancer treatment delivery. And I'll leave you with a quote from the original Wolf and Johnson paper that I refer back to many times. As a society, we should confront the price we pay in human lives by maintaining a healthcare system that is not designed to deliver care well. Society can realign its priorities. It can spend less excessively on the enhancement of drugs and technology and redesign systems of care to ensure a standard of excellence. Failure to act to correct these deficiencies in fidelity is, in effect, an affirmative choice to subject patients to greater illness and suffering. To do so while investing in vast wealth and technology should weigh heavily on society's collective conscience. And with that, I will say thank you for giving me your attention and your time. And I'm open to questions and discussion that the group may have.
Thank you very much, Mike. What an excellent presentation. And you did reveal the secret way to cure cancer. That is to develop drugs and to give those drugs to the patients who need them. And of course, like we say that only those drugs help patients that can reach the patients. There is no point in having all these fancy drugs if they can't reach the patients. So really thought-provoking and yeah, excellent talk as always. So thank you. So we'll open the floor for questions.